We're going to talk about exercise and activity, and then we'll be talking next after that about rehabilitation, because they sort of kind of go hand in hand with each other. So it's really important for our residents that when they can't move a body part, or when they're injured or have a disability, that we are moving them. When patients don't move, their sense of well-being is decreased, they get contractures, they get atrophy. So we're going to be talking about what those things are and the importance of how important it is to move patients and do rehabilitation for them as much as we possibly can. So when we're looking at, do we do activity or do we do bed rest? Nurses usually use what we call the nursing process to promote exercise and activity in all people to the full extent possible. Being active is important not only for physical well-being, but just for your emotional well-being as well. Now, occasionally bed rest will be ordered to reduce pain, to encourage rest, to regain strength, to promote healing, but it's actually a fairly rare order to see. So there are different types of bed rest. You can see strict bed rest where everything's done for the person, and we do all their activities of daily living, and that's not really a part of rehabilitation, obviously, but that's if they have a disease process where it's really critical that they're conserving their energy and conserving their oxygen as much as possible. And then there's bed rest, where they can do some of their activities of daily living for themselves, but basically they have to stay in bed. They can bathe what they can reach in bed and stuff, but they can feed themselves while they're in bed, but they can't get out of bed. And then there's bed rest with bedside commode privileges, where they can get up to a commode or go to the bathroom. And then there's bed rest with bathroom privileges, where they can get up for the bathroom only. Now, generally when we're talking about bed rest, we'll usually see an order like that possibly in a hospital when the person is going through an acute process. But when we're looking at in a nursing home and we're looking at rehabilitation for our residents, this is going to be a very rare thing to see. So some complications of bed rest that we might see are pressure ulcers. So we talked about how when we have a person who can't move a body part, they have a disability, it's really important that we keep them moving. If a person is sedentary for long periods of time, if they can't move, if they can't turn themselves, we can get pressure ulcerations. And common places to see that are on the sacral area and on the heels, sometimes on the ischium if they've been sitting for long periods of time. So we always want to try to avoid that as much as possible. We want to keep people moving when they're in bed. Even when we're not working on them with PT or getting them up for rehabilitation, we want to make sure if a person is staying in bed while they're in bed that we're still moving them. Skin tears, because if they're thrashing around in bed, their skin can tear, it can shear, against the bedding. Constipation can happen because if a person's inactive, normally with our elderly population, they tend to have more of a tendency to constipation anyway. But when a person is not active like they should be, you will end up seeing issues with the peristaltic waves that go through the body to help things move through the gut slow down, and so they're more prone to constipation, and then that can lead to fecal impaction. Urinary tract infections, it's hard to empty your bladder all the way when you're having to lay in bed to go to the bathroom. And they're more prone to kidney stones, which are called renal calculi. Another concern that we always worry about when someone is on bed rest and they're not moving is blood clots. Those are known as thrombi or thrombus. And when a person lays in bed and they don't move, anytime blood is sedentary, it tends to start to clot. And so then what can happen, which is a thrombus, then when we do start moving them, that thrombus, that blood clot, can break off and travel to another part of the body, and that is called an embolus. Pneumonia, which is inflammation and infection of the lungs, just because when a person's laying in bed all the time, they don't take nice deep breaths, it's harder for them to cough, to get any secretions out of their lungs. And bone loss. After 10 days of bed rest, you can actually start losing bone mass. So bed rest is not a good thing for a patient ever. Another thing that we see sometimes is orthostatic hypotension, and that's when the blood pressure drops when they stand up too suddenly. It's really common in our elderly population. You also see it in patients that have dehydration. And so when they stand up, really, normally when you stand up, when you go from a lying to a standing position, you have valves throughout your body that kind of shut off to help keep blood in all the areas of your body so things don't just drop to your legs when you stand up. But when you get older, those blood vessels, those valves don't close very well, and you're more prone to orthostatic hypotension, where the blood flow from the upper body drops down to the lower body when you go from a lying to a standing position too quickly. And then they feel faint, and they can have what we call a syncopal episode where they pass out. Now, it's not going. Another thing that happens when people are not moving is atrophy. And atrophy is muscle or tissue wasting away from lack of use. And so it is something that when a person is not moving, we always need to make sure we keep them moving to keep them as active as possible. Another thing we will see is what we call foot drop, where if they're not bearing weight on those feet and you're not using the foot and it just continues to drop down, it'll actually start staying in that position. Contractures, which is a lack of joint mobility by abnormal shortening of a muscle. Hands are a really common place that we see that, because generally when a person does have a disability or they have a weakness on one side, nurses are usually pretty good about doing range of motion to the larger joints, but sometimes those hands, those fingers take a really long time to do range of motion to, and so sometimes it's kind of an area that you'll see be overlooked. Now, sometimes people will come in with these things already when they come into the nursing home. So for instance, if a family member is trying to take care of their loved one at home and they didn't know that they were supposed to be doing range of motion, they didn't know that they were supposed to keep the body moving, or the atrophy and contractures, that this was going to happen to them, and pressure ulcerations. So sometimes when they get into a facility, they already have these things in place. But when they don't have them and they are coming to us originally after an injury, we need to make sure that we're preventing that from happening. So postural supports are something that we use a lot. And so there are different types of postural supports. Something like this one here will actually keep the hand in a more natural position so the fingers can't curl and crink up. It'll help keep the wrist in a more normal position. They have splinting devices to help keep the foot from just dropping down. They have variations to this. So there are multiple different types of postural supports. You'll see trochanter rolls to keep the hips from turning outward, and an abduction wedge. And a lot of times my students will ask me, well, wouldn't this be a type of restraint because you're tying the legs to it? We kind of have to look at what's the intent of it. So when a person has a hip surgery, for instance, when a person has hip replacement done, it is critical that they don't cross one leg over the other. So if this is the surgical site, it's really important that they don't take this leg and cross it over that leg. And people forget, especially when they're sleeping. So when they're in bed, this will kind of keep their legs separated. It'll keep one from crossing over the other. And so we're using it as a postural support. We don't mean it to be a restraint. So we do have to look at the intent of how they're being used. This is another type of board that can be used to help prevent foot drop. And this right here is called a bed cradle. And what it does is that one end of it attaches to the top of the bed and one slides under the bed and holds onto the bed. And then this part right here, this cradle part that goes over the bed, you put the sheets and the covers over it so they don't put a lot of weight on the toes. And this will help prevent people from having the weight of the sheets and the blankets help hold their feet in a low position where they can get foot drop. It'll keep sores from happening on the top of the feet and extra pressure from pushing down onto the heels. So a lot of times you'll see foot cradles or bed cradles. This is a trapeze bar. If you do have someone who is staying in bed a lot, if they have upper body strength, but maybe they're having to go through rehabilitation for the lower body, they can hang on to this trapeze and help pull their upper body up. So sometimes this will be a nice device for the person to use if they still have upper body strength. Prevention is critical. Prevention of atrophy, that muscle wasting away, prevention of contractures where you have the abnormal shortening of a muscle is really important. We need to do range of motion exercises. We need to move those joints to their full range as possible without causing pain. So there's active range of motion, which is where the patient is actively moving it themselves. There's passive range of motion where we're doing it for them. And there's active assist, which is when someone can move it part way and then we'll move it the rest of the way. And sometimes I have to tell you, sometimes these residents can do a lot more than you think they can do. You think you're going to have to do it for them, but many times they can actually do it themselves. So you always want to give them that opportunity, always see what they can accomplish on their own without us having to intervene. OBRA, that Omnibus Reconciliation Act in 1987, requires that elderly patients are assessed and proper planning done to prevent unnecessary loss of range of motion. So OBRA says, okay, if this person has a disease process that is progressively getting worse, so let's say a person has multiple sclerosis or they have Parkinson's, that's a neurological disorder, and it's going to, they're going to continue to deteriorate. So with Parkinson's, they're going to continue to get worse. But we can keep that we can slow that down as much as possible. We can prevent unnecessary loss in their range of motion. We can keep them as active as we possibly can for as long as we can. Now, if you have a patient who has had a stroke, and let's say they have weakness on one side, that's called hemiplegia, weakness on one side. Let's say they they can't move one side. We have a responsibility to move that side then, to keep the atrophy and the contractures from happening. There would be no reason. Their stroke isn't going to progressively get worse. Their stroke has caused a certain amount of damage, and that's how much damage is there. We should be able to prevent it from declining worse. Children's range of motion a lot of times can be turned into games. You can get them to move their fingers by like tossing a ball back and forth, or move their arms. So you can actually play games with kids to start getting their range of motion going. But you never force a joint. You always, when you do range of motion, you move a joint gently, you move it to its full range without causing pain, and you always support the joints when you're moving them. So some range of motion terms, there is abduction, which is moving away from midline. So if I'm lifting my arms away from the body, that is abduction. And if I'm moving towards midline, towards my body, it would be adduction. I always think of it as adding it back to the body. Flexion is bending a body part. Extension is straightening it back out. So those are common terms you will hear. There is also what we call dorsiflexion and plantar flexion. And plantar flexion is when you take the foot and you move it all the way down, and dorsiflexion is when you pull it back up. So plantar flexion, dorsiflexion. And I always remember that one like I'm planting my foot down. Okay, so that motion has another name to it. So when we're doing range of motion, we do need to make sure, so if I'm doing range of motion to the shoulder, for instance, I'm going to support the arm at the elbow and the wrist. I'm going to move it through its full range. I'm going to move it gently. I'm going to let the patient, tell the patient to let me know if anything hurts. And a lot of times the physician will order how many times he wants range of motion done. So sometimes I've seen orders like range of motion 3 times a day, 5 to 10 times on each joint. But usually if it's not specified, we do at least 5 on each joint. Now if you get this skill for state competency, they will only you only have to do it 3 times in each direction, but generally 5 is pretty typical. So range of motion rules: exercise the joints that the nurse tells you, move the joint slowly and gently, do not force a joint beyond its present range. Normally we said each joint will be moved 5 times unless the physician has ordered 10 times each joint. Stop if they're having pain. It's usually done at least twice a day. Sometimes the physician will order 3 times a day, or I've even seen orders for 4 times a day. We do not do neck range of motion without checking the facility where we're at. Most of the facilities we go to, they will not allow the CNAs to do range of motion to the neck. Because if you push that too far, you move it too far, you could actually injure the neck. And do not do range of motion to an extremity that has had surgery to it without checking with the nurse or the physical therapist. So if they've had a knee replacement, a hip replacement, a shoulder surgery, you are not going to be doing range of motion to that body part without checking in with that nurse or the physical therapist to see if it's okay to do it and to what extent and exactly how they want it done. The term ambulation is the act of walking. And if they're weak, what we like to do is we like to dangle them. And dangle them is when we sit them on the side of the bed and just let them sit there for a little bit and kind of adjust. And then we will stand them up, and then we'll start moving them. Because sometimes they get that orthostatic hypotension where their blood pressure drops when they get up too quickly, and they might actually feel faint and pass out on you. So ambulation will prevent deconditioning. It will prevent loss of muscle strength. Now, if our resident is a fall risk, we are going to use a gait belt. And the gait belts, we've talked about these before. They go over the clothing. They're put on snugly, not, they're put on snug, not loose. The buckle should not go over the spine. Excess strap, you would tuck it in so it's not dangling, and you would not hold it on top like this. You actually hold underneath the gait belt, because if you're holding it like this and they start to fall, your hand can just slip right out of it. If you're holding it this way, even if they start to fall, you can help control the fall. You can actually help them, guide them down to a low position without hurting themselves. People should always wear shoes or non-skid footwear. Encourage them to walk as normally as possible. And if they do have a weak side, we are going to walk to the side of them, slightly behind. So here's their shoulder, here's my shoulder. So they're right here, I'm right here. I don't want to walk directly behind them, because then my feet are going to be kicking into their feet and potentially knocking them over. But I would walk on their weak side. If they had a cane, cane would go on strong side. So walking aids that are ordered for the patient for safety, they can help support the body. There's crutches when a person can't use one leg, but they would have to have good upper body strength. So I can't say I've ever really seen crutches used in the nursing home, but you do see canes and you do see a lot of walkers there. And canes are used for weakness on one side of the body, and it is held on the strong side. So you would be on weak side, canes on strong side. And there's the 4-point canes, or there is 1-point canes. And then walkers, there's either 4-point walkers where they actually lift up and move forward, or there's front-wheeled walkers where there's wheels on the two front legs of it, and that way the patient can just roll it and they can do a more natural walk. So when a person needs a walking aid, usually the physician will order for physical therapy to evaluate them and to determine what they think that they need. So usually the physical therapist will determine what is the best walking aid for the person, what's going to be the safest way to do it. And then we can use braces or splints to support weak body parts if necessary, but if you are using a brace or a splint, make sure the skin is really kept clean and dry underneath it. And if they're having pain or any breakdown under the skin, we would want to make sure that we let the nurse know. These are some orthotic devices. So an orthotic device is something that we can use to support a muscle, to promote motion, or to correct a deformity. And these type of orthotic splints like this, they're usually custom made. They're actually, made to fit specifically to the person's foot and to their leg. They will go inside, the shoe will actually go over it, so the foot goes in here and the leg goes in there. Some of them have straps. Some of them, once you fit the foot in there tight, you're good to go. And then that will actually go into the shoe. But there's different types of orthotic devices just to help support muscles and correct any deformities that are there. Now, recreational activities are something we will also see for residents. OBRA, that Omnibus Reconciliation Act, it's a federal law that's involved with care in the nursing home. It requires activity programs for residents, and it requires the facility to provide a variety of activities to meet a variety of interests. And so there's usually a big calendar up on the wall that'll have activities calendar, and every day there's usually 5 or 6 different activities to choose from throughout the day that people can go to. Again, many of these people live there. We don't want them just staying in their room for the rest of their life. We want them involved. We want them to have a sense of community, a sense of belonging. We want them to get out of their room. We want them to do things. Now, we cannot make people go into activities. People have personal choice, is always protected, but we should always try to encourage them to come out of their room, encourage them to, do other things, just to give them a change of scenery and to keep them as active as possible. So we do always want to make sure that we're helping protect the skin, and one of the ways we do that is when we are moving patients, when we're positioning patients or moving them, we don't want to drag the patient up or across the bed with a draw sheet. So we can lift up, we can roll the draw sheet up and lift them up in bed. You don't drag them up in bed because it can cause what we call shearing. You can have shearing and friction. Friction are where two surfaces rub together, and shearing is when, like if I drag a person up in bed and their skin is all sweaty and it has stuck to the sheets, and now I'm dragging them up and their skin is stuck to the sheets, I can just tear open the skin. So get help when we're repositioning people. Encourage proper positioning when they're in bed, when they're in a wheelchair. If you notice skin areas where there's skin redness, maybe from pressure or from tubes sitting in an area too much, we don't massage reddened areas because we don't know if the skin is starting to break down underneath it. So you want to not massage reddened areas, but you do want to make sure you support areas of redness or injury to the nurse so we can aggressively get them help and treatment before it gets any worse. When pressure ulcers tend to get worse, they can get infected even. So we're going to stop at this point and we will continue soon.